Hello, everyone. Thank you very much for joining us today. My name is Rachel. I'm the marketing manager at Current Health, and I'm joining you today from our lovely office in Edinburgh in Scotland. I'm delighted to welcome everyone to today's webinar on health equity and care at home. Our presenters for today are Jessie Lever-Taylor and Tracey Baker from Current Health. And we're also joined by Melissa Lutz from Health First. In terms of background, Jessie Lever-Taylor is our clinical research manager, where she oversees operations and implementation for research collaborations, as well as being an integral part of our internal usability team. Jessie previously worked as the content manager for Scantovia, and outside of work, she fosters cats and dogs and enjoys hikes, running and cooking. She joins us today from Brooklyn in New York. Tracey Baker is Current Health's Senior Director for Implementation and Clinical Operations and has over 12 years experience in the healthcare technology industry. Tracey previously worked at Limbongo and Teladoc, and outside of work, she enjoys traveling and sailing. She joins us today from Chicago. And Melissa is the nurse manager for the Hospital at Home programme at Health First, where she is responsible for building and empowering a team of nurses to provide high quality in-home care to acutely ill patients. Prior to her current role, she has served as an emergency department nurse for 13 years, supporting numerous clinical projects. Outside of work, she enjoys gardening and spending time with her family, and she joins us today from Melbourne, Florida. For those of you joining us on the webinar today who are unfamiliar with Current Health, we provide a care at home platform which combines remote patient monitoring, telehealth, and patient engagement tools, all of which can be configured to support care across clinical conditions and different clinical conditions and acuity levels. Today, our discussion will be focused on the evolving conversation about health disparities, equity, and care at home. We'll also discuss how to centre equity in designing, launching, and scaling your programme. And then we'll speak with Melissa and how the team at Health First prioritises equity within a hospital at home programme. Next slide. We are very privileged to work with numerous organisations across the UK and the US, and we're really pleased that Melissa's joining us to share Health First story today. And with that, I will pass over to Jessie to start our discussion.
Hi. I wanted to start by defining what we mean by health equity. This definition from CNMS defines it as the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, and other factors that affect access to care and health outcomes. I want to emphasize that health equity isn't about equal access to health care, but it's really about achieving equal outcomes for all. So what affects health equity? The CDC identifies health disparities as preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. On the right, you can see the factors that affect a person's health outcome. It's seldom just one, but several together that cause the overall effect. I wanted to put this quote here because I truly believe that we as digital health providers have a huge responsibility to help keep health equity at the centre of everything we do. If we don't, as this quote highlights, we run the risk of making things worse. Tracey is going to go into more detail about what this means in practical terms for setting up programmes, but building and testing tools within the communities that will benefit most is paramount. Health equity isn't about equal access for all. It's about providing a boost to traditionally overlooked communities. Health equity isn't a new concept, but recent guidance and announcements from CMS are putting a lot of attention on this topic. We're starting to see standards and support for measuring and pursuing equity. You can see some of these on the slide. Community leaders have been sounding alarm bells on health equity for years. The healthcare system has often fallen into pursuing the easier to reach populations, and this has led to missing huge swathes of the population who are traditionally not well served by the HMO insurance models we have. This focus by CMS has finally given permission to healthcare systems to work to really actively include these groups. Access to high-speed internet, something many of us on this webinar probably take for granted, has been called a super determinant of health. And this has led to the Affordable Connectivity Programme, which aims to bring high-speed broadband to 38 million Americans. We still have a long way to go to achieve health equity, but starting to focus on it and talk about it feels like a good start. Increasing access to broadband, etc. is great, but I want to stress again that access alone isn't enough. Coming back to the idea that health equity is fundamentally about improved health outcomes, we need to ensure that people don't just have access to it, but that they have the skills and knowledge to use it. It needs to be designed thoughtfully so as to be accessible and usable by all members of a community. And then we need to ensure that we don't just measure things like activation and adherence, but go all the way through to health outcomes. If we don't get our product design, user interface, and usability correct, we can definitely end up widening existing health disparities. At Current Health, we're very focused on human factors engineering and usability. We strive to test new features and designs on a wide range of people who are truly representative of our end users. I'm now going to hand over to Tracey, who's going to talk in more detail about health equity in a care at home program.
Great. Thanks, Jessie. And thanks to our audience for joining us today. You know, there really isn't a better time in our own history to sort of talk about health equity than right now. The pandemic and everything we've learned from our customers in the US and the UK over the last 2 years has really shed light on how important it is for the health of people of color, for women, for the LGBTQ community, for rural populations, inner city populations, and the aging population. I really in my lifetime can't think of a better time than right now to be having this discussion. You know, when Jessie and Rachel and Melissa and I were all preparing for this, we came at this from a very deep place of humility that we have the privilege to sort of talk to you about this and share stories from our customers on how they're taking care of populations at home despite social determinants of health. So, you know, just really quickly before I start, two kind of stats that came out to me when speaking with folks in my network about health equity and researching for this webinar is what I think is really telling is sort of the data we're seeing coming out of rural America and even inner cities too. It's, you know, 1 in 5 Americans, so 20% actually live in rural areas, and there's a major crisis of access. There's closures of hospitals that have led to rural populations having 1/2 the access to primary care physicians and 1/8 the access to specialists. So what we're seeing at our health centers that are implementing our technology is they're actually reaching those folks despite demographics. You know, those folks aren't receiving preventative care. They're experiencing major hurdles to broadband connectivity and transportation. And as a result, folks in rural America actually have a 23% higher mortality rate than the rest of us. The other telling stat is that Black and Hispanic people are almost twice as likely to die from COVID. That comes from the chief equity officer at CVS, who was part of the Biden administration. So if those aren't two main reasons why we shouldn't be having this discussion today, then I don't know what is. So, you know, there's no perfect answer, but we're just trying to remain intellectually curious through this presentation. Next slide, Jessie. So, you know, one of the reasons we're having this webinar, it's for both prospects as well as current customers, as well as anyone who wanted to join. So one of the reasons that we put forward this webinar is that we heard from a lot of prospects that they were sort of scared, like, how are we going to do care at home in underserved, rural, and impoverished areas? And in actuality, what we saw with our current customers, and I can speak very closely to this, is our team just completed 100 home visits with one of our customers, that more often than not, the homes that we were going into and seeing were actually facing a ton of social determinants of health. And what we learned from those customers is that pursuing equity within a care at home program is not necessarily a milestone on a project plan that will simply be marked off, right? It requires attention, consideration, and humility at every stage of the program. We'll hear more about this from Melissa, but what I think you'll hear is that in each stage of setting up your program for care at home, you have to sort of have that equity mindset with involvement with patients and populations. This has to be part of your strategic vision and goals. When you're thinking about clinical and operational workflows, inclusion and exclusion criteria, and even your monitoring and alarms, you have to sort of keep in mind the inclusion of all people, of all colors, of all races. And when you're building the care at home program, time and time again through our research and hearing from our customers, is you have to center training and engagement around programs that help us kind of combat our unconscious bias and then scale, right? So, we're seeing lots of our customers scale into demographics and into locations that they wouldn't have necessarily thought was possible when they set out, but they set out with the mindset that they were going to do that and therefore are achieving it. Next slide. So what are some of the operations and processes we've seen our customers set forward? Again, provider engagement from the onset, thinking about patient eligibility and identification through a lens of health equity, thinking about patient enrollment, education, and activation through a lens of folks might be scared. You have to build trust in order to make these programs successful, and you're inviting yourself and our technology into a patient's home, and that might be scary for some people. And then of course the monitoring, alarming, and the actual discharge and care coordination afterwards. I know Melissa's going to talk a lot about how her team has done that to make sure that when folks go back into the when they're discharged from care at home, that they have that support within their community to continue to be well. I think what this slide, what this slide really says is that, if there's intentionality, then actually you can decrease the disparities. Okay, now next slide, Jessie, sorry. All right, so we're very, very upfront about this. We know that technology can either be a bridge or it can be a barrier, right? And when I think about this slide, I think of one customer that we have in Texas, and they are using both continuous and intermittent monitoring within their population. So they came to us and said, we really need to take care of folks that are living with hypertension. And we know that much of that population that we're working with don't have the means to do this technically. So we need you to provide a blood pressure cuff and a tablet so that we can reach those communities. Additionally, we need, continuous monitoring to stand up our hospital at home program. We're helping them there. There are challenges, right? There's going to be challenges with broadband and with connectivity everywhere in the United States. But you sort of can get over that with technology that is easy to use in the home with the patient, and not sort of relying on, what we've relied on before, which is we all want to take out our iPhone and be able to use it right away without a manual. Being able to, within your program, set up confines and guardrails and education to help both your nurses, your clinicians, and your patients succeed with technology. Next slide. Perfect. So in the home, the realities of our patients' daily lives. So this is so telling. I know I have a few folks from the UMass team on this call, and we're pretty open about our relationship with them. So I'd love to just draw on two stories here. In March, we got to go on 100 patient visits with them, and 2 homes that I went into would normally, in sort of a product designer's head, probably be unfathomable. But what we are really doing with our technology and what our programs that we serve, we're seeing do, are actually pushing the limits and pushing the boundaries of the homes that you can go into. So going into homes with low broadband. But this is sort of something to think about as you build your program. Your nurses, your patients may be living in places that you haven't thought about delivering care in before, and you have to sort of take that into consideration. You have to take into consideration the types of homes and buildings they're living in, their types of actual living arrangements, their conditions and possible safety challenges, utilities, things like AC, food insecurity, as well as just connectivity and electrical outlets to actually use the remote patient monitoring devices. So 2 quick stories. One story was a place that I went into. I'll call her Luna's sister. She lived in a basement apartment. She had 4 animals. They were smokers. It was such a intimate experience, and the technology worked perfectly. And the patient was so excited to be a part of the program, was discharged within a few days so that she could go to a hockey game. So her goals were met. The other story was of an older adult. So I used to be in geriatrics, so this is very near and dear to my heart. But this woman was in her 80s. She had dementia. She had delirium. She was very immobile, and the UMass team was able to care for her in a very difficult situation for several days using remote patient monitoring technology with us. Next slide. So again, calling out the UMass team, and I know Health First does this too, what's really important is to look back at your quality, to look back at your outcomes and the people you are serving as part of your quality endeavor. This should just sort of be part of your quality program, right? So if you're sort of looking at your program a month or a quarter in, and the populations you're serving don't really match the demographics in your area, then you might be doing something wrong. I think of the sort of well-known story when large cities started rolling out vaccination sites. What they found is that people were coming from other zip codes that were well served first, and they weren't actually reaching the zip codes and folks within those communities that they intended to. So looking back at your data to see if you actually are reaching those populations in those areas, and then intentionally driving yourself towards serving those more programmatically will make your program a success in reaching health equity. Next slide. All right, so how do I engage my target populations? So we love the idea of making sure you're including your Care at Home program in PFACs, working with your internal health equity team. Once your program is live, making sure that members of your community are presented and are represented, as well as looking at those demographics, and review excluding patients. So, I want to turn it over to Melissa real quick to tell us a story about how they sort of look at their inclusion and exclusion criteria and look back at it to improve it.
Thank you, Tracy. Good afternoon. Thank you for having me here, first of all. Second of all, the way that we operate our program is we have an initial, what we call a sweep. We go through all of our hospital bed bases. We go through all of our EDs. We're currently live at 3 out of our 4 campuses. And we do an initial sweep to see who hits those top box, has the right, insurance, has the right level of care, et cetera. Go through that. We then work our way through to divide that list, and there becomes an exclusion list and inclusion list. The inclusion list gets worked by the coordinators in order to figure out who would be accepted or medically cleared to come with us in the program that day or in a couple days. The patients that are excluded go onto a watch list. That watch list is reviewed, generally speaking, throughout the day. I would love to say we're organized enough to do it at the end of the day, but it's generally done throughout the day to go back and see what the exclusion criteria was that it didn't fit. When we started doing that on a regular basis, we found, because one of our initial requirements to be within the program, because we utilize a remote monitoring system, is that you had to have internet access. And it was a little bit of a gut check when we saw all of the patients that were automatically eliminated just because of the criteria feed down, because they didn't have internet access. So we started to take a deeper look at that And now it's just kind of habit where, if we see a patient that's, included for every other reason other than the fact that they don't have access to a luxury item, truly, when it comes down to your basic living expenses, we send out our team to make sure with our current health products that they connect with cellular data. And even to troubleshoot past that, we're currently looking at, do we have at Health First, we're a large organization, do we have an ability to set up a intermittent internet activity for them for better coverage for the video portion of it. We do this pretty much with any patient, regardless of their status, to make sure that we are meeting their needs. And obviously we target patients who are in need of greater education, have multiple comorbidities. We're not, just talking about a one-time infection that didn't, failed outpatient therapy or something like that, where we work with our transitional care team in order to work on patients that have acute diagnosis that's a chronic issue, and they usually have several of them. We have a lot of CHF COPD combos here in Florida, and a lot of those patients were getting kind of missed by the wayside if we just followed that strict list. So upon revising that list, we now, like I said, go back through and we look at every single one of them to make sure that the exclusion reason is not due to because they don't have the same setup that I have at home or that you may have at home, that we're reaching the people who truly need us the most, because those are the people who are going to come back in time and time again, because, we have to create a bed. We have to create a bed to keep caring for sick patients, and they don't get the education time that they need. They don't get the resource time that they need.
Yeah, that's right. So I think this is a perfect segue into the interview portion, Melissa, if you're good with that. So Jessie, I think maybe we're 2 slides there to advance. So, Melissa, please, you've been live with your hospital at home program now for just about a year. So please share a little bit about the patient populations you're treating within the hospital at home program at Health First.
So when we initially started our program almost a year ago, we had a list of 7 diagnoses because everything on a tabletop looks nice and pretty when you can put it in those lists, those little compartments. We no longer look at specific diagnoses. We look at clinical criteria as far as medical stability, both by nursing tasks and also by obviously your provider feeling that they can continue safe care within the home. So we got rid of that list. And then, we're talking about the exclusion lists that we have. We have lots of lists down here where, we had to let go of that list to be so tight and finite outside of safety or just a clear ineligibility due to a factor such as, IV drug abuse history or something to that effect, where we can't send them home with an IV in place. So outside of those like hard passes, we go back through and we relook at them. And then even a couple days later, we go back through and make sure that they still don't meet those watch lists. Although created daily, they're evaluated multiple times throughout the day, multiple days later, because we watch them from the time they come through that door, that it could fit something that we have cared for in the home prior.
Yeah.
We have so many elderly individuals that are on very restricted budgets here. So a perfect example for when it really hit home with our nursing team, this is in our very infant stages of the first couple months, when we were speaking with the patient in the hospital base, getting ready to take him home from the ED. We asked him if he had any food insecurities. We didn't use the word food insecurities, right? But, did he have food at home? Was he able to care for himself? Was he able to cook meals, et cetera? And he told us, yes, absolutely. Of course he has food. CHF patient who had a couple frequent admissions. So, get him home. Nurse goes into the home And we go through and do a medication review to get rid of expired medications. We also go through and we do a food checklist, right? Make sure that they really do have food. And this gentleman did have food. He lives on extremely strict income. He was in a trailer type of home. And inside his cabinets, come to find, was, your Chef Boyardee, your top ramen, everything that fit within his budget for grocery shopping. So in his head, he totally had food. And now we know why you continually are bouncing back, because your, sodium intake is through the roof. Having those conversations with him, going through, we have community resources that we can go through to make like grocery budgets, where they can get fresher foods in place, where you can choose something over another item that has a higher sodium content or higher, fat content or what have you, in order to keep them healthy in the long run. It's great when we're there. Everyone behaves when we're there, right? It's when we leave that we're concerned that we fall off the boat, because we do the same thing. It's human nature.
Right. I really appreciate that, especially what you said at the beginning about your 7 sort of profiles. What we've heard from other customers is that you can set 7 profiles, but no patient ever fits directly within any of them. So to have that understanding and flexibility is important. Let's talk a little bit, and just for the group, so everyone knows, this is a recorded session. We're actually going to go longer than the slotted time, because we want to make sure that we hear from Melissa. So we'll record this and send it out, as well as the slides. But we are gonna go over. So Melissa, in your role as a nurse manager, how do you think about patient equity when hiring and training your staff?
So within our program, you have your initial interview with myself, a couple members of the team. What we then do is we require you to do essentially a ride along, if you will, where they will go accompany a nurse to go on at least 1 or 2 visits. Within our community, we have a larger portion of elderly people, as I said, and they collect a lot of things over a lot of years, and they shove them in a lot of corners. So going into these homes that are not necessarily kept maybe the way you or I may keep our home, and figuring out how we're going to crawl under something in order to plug something in, or set up a clean space for the patient to get a wound dressing change or something to that effect. We have that candidate go along so that they're actually seeing the role to which they are truly applying. Because if you read it on a piece of paper, it, essentially looks like home care. And it's a little bit more than that. After they've completed that part, if they're still interested, we then pull them into a scenario to see how they handle problem solving, because you're a one-man show. When you walk into that home, you have a ton of support in the background, but it takes the background a few minutes to come to light. So we have them go through some thinking scenarios, some crisis intervention thing to see if they have any of that in place, and just generalized safety measures. But everything is a team approach for us because we hire for fit. We want to make sure it's the right person within the roles that we have available through our program when they're available.
Perfect. How does your team measure and operationalize equity within your patient population?
So our measurement truly comes on the back end. We partner within our organization, we have a transitional care team. Traditionally, the transitional care team followed, for the most part, your core pathway patients. We partnered with them so that each of our patients, once discharged from our program, they have 30 days of checkup. In partnering with TCT, we also have connections within our medical groups to try and find a way that we can measure the compliance rate with follow-up, right? That's a huge part of it. TCT helps push them and get them, additional resources if we haven't already given them to them. But we're trying to get that leveled out so that we can have another measuring process, in that manner as well. But we also have private community physicians, so it's not going to be 100%. We do measure for the hospital status side. We measure our readmission rates. How are we doing comparatively to the rest of our hospital. And, currently we're at 6.8% for our year, and the hospitals themselves are at 14.7. So, we're doing something right there, right? So we keep measurement with that. And when they do come back, we attend a huddle in order to see what happened. Where did we drop the ball? Not just hospital at home, but collectively. Did we give this patient everything that they needed? And then we also measure, our length of stay within our program. We do two separate. We do the hospital whole length of stay that they were within Health First Care, and then we do, our hospital at home status, and make sure that we have got all of their different needs met through our checklist to make sure that each of those things are ticked off before we discharge them.
Perfect. So going back to sort of the staff, the staffing model, as well as how this delivery of care maybe changes your mindset or others. So tell us how this care model enables a deeper sense of compassion, trust, and relationship building between the patients and the nurses. And if a specific story comes to mind, we would love to hear that.
So we like to say that this is what we went to nursing school for. We're getting back to the basics. We're doing the human connection. Unfortunately, our healthcare system is so inundated with so many people who need us that it's absolutely impossible in order to meet those needs within those brick and mortars all the time. With the hospital at home team, we're able to invade essentially their most intimate and safest spot. We get a lot more frank conversation with these patients than I ever imagined in my entire career I would actually have with a patient. We had a gentleman who was with us for an extended period of time. He had some multiple comorbidities, and he had kind of, as he said, let it go until he became very sick, wound up in the hospital, and stayed with us in hospital and home for a good almost a week. And it was right before Christmas. He kept teasing us, saying he just wanted to get discharged for Christmas. That's what we could give him, just wanted to get discharged for Christmas. When we entered this gentleman's home, it was very filthy, multiple pets, very filthy, not like any home that we had been in until that point, as far as the level of kind of where he lived and what was surrounding him in that environment. My nurse left the house that day, and she called me, and she was not shaken, but upset that this, poor gentleman is living in these conditions. And he was just his only concern was his dogs, make sure his dogs were okay. So he said, you know what, let's do something. How Christmas elf do you feel? Knowing that this is not a service that we generally provide. But we just connected with this guy and knew that he just needed a little bit of help. We didn't know why yet, but we knew that he needed a little bit of help. So we gathered about 8 members of our team, including our current health rep was actually down for a visit. She decided to join in with us, and we all threw on Hope was great. She was such a team player about it. All threw on some, yucky scrubs and went into this gentleman's house, and we cleaned it. We didn't clean every single room, but we cleaned all of his main living areas, made sure that his kitchen was clean so that he had a safe place to cook his meals, to prep his meds, cleaned up all of his living spaces that he invaded, on numerous times throughout the day, as well as bathrooms in his bedroom, etc., so that he had safe walking paths and he had a clean environment that his wounds could heal in. As we were chit-chatting with him, started to talk more personally about, we knew that he had children that lived in a somewhat close area, but, it's a very large house. Why don't you move closer to your children? Is anything holding you back from that? Come to find out, the room that we were kind of focused with, what we thought was his bedroom, was actually him and his wife's room. And he hadn't slept in it in 7 years. We kept, nurses are nosy, so we kept asking questions, and he was more than open and willing to talk. And He had not cleaned that house. He had not done anything with that home since she passed away 7 years ago via hospice within their own home. It wasn't a room that he could go in any longer. And she was a homemaker. He made the money and she was a homemaker. He just grew up in a different time. So when it came to household chores, that wasn't something that he was well versed in, so to say. So for Christmas, we did this, and we were actually very lucky. I went out myself, discharged him Christmas Day, and thanked him for letting us help him, not to create shame, not to create any of those specific scenarios, but just to give him the right footing and foundation in order to move forward with that.
Yeah, it's such a powerful story, Melissa, and Hope shared that with our team, and it's a profound moment in kind of, I think, everyone's experience of delivering care at home. I'm going to go off script for 1 second before we get to our final question,
Sure.
But I know this is probably top of mind for some of the folks on the call. Talking about hearing your story and the experience of your team going in to help clean this gentleman's house and being very intentional about providing care in a equitable way. What does that do to your staff? Does that kind of get you closer to some burnout? Does that actually help them find the vision? Like, talk to us a little bit about how your staff deals with this intentionality of taking care of folks in an equitable way.
So we provide any opportunity for debriefing. We also provide a not an RCA, but a way that we can run down if we do have a nurse who just doesn't feel like they're doing enough or is closer to burnout. We haven't truly experienced that, but we do have those methods in place because it's such a bucket filler. They get to actually connect with each and every one of these patients. They are humbled. I am humbled every time you leave a less than adequate environment to what we live in. It's very easy to put on those blinders and think, well, I may not live lavishly, but everyone's got these basics, right? We had one patient who lived in a very impoverished area and had no AC in their home. And that's not, it was broken and they never got it fixed. It was that they never had AC. And a couple of the nurses, it was a COVID patient. So you've got all of your gear on. A couple of the nurses kind of were angry leaving because it was so hot and they're sweating, so profusely. And came back to the office to cool down. And they start telling me about this patient. How do you not have AC? How is this safe for them? They're going to it's Florida. It's so hot. We're going to hurt them more. And we kind of just had to do a real timeout. This is the patient that needs us the most. Not the one sitting in the AC in the brick and mortar, not the one sitting in the home with the AC fully blowing on them. This is the patient that needs our touch. This is the patient who needs our education. This is our patient that needs resources and needs to know where to go to get those resources. And have we even checked whether they have transportation to get to those resources? And we'll do that pretty frankly, just like that. Time out. We've got to look at this in a realistic manner because we can't pretend that these people are not part of our community just because we don't see them. When you're in a brick and mortar hospital, everybody's the exact same. Doesn't matter what you're going home to. We have a very fortunate and wonderful, wonderful nursing team who we don't really experience burnout because it fills the bucket more. They feel more empowered now as nurses to actually make impact and show care and compassion to their patients than they had previously. So it's actually been a refresher for them. But there are lists and conversations in place that we can debrief if that is the case and we catch it sooner versus earlier.
Right.
But we haven't gotten there yet.
Yeah. All right, final question, and then Katie's gonna, I think, potentially yell at me.
Oh, yes.
So no, we're on time, but last question. So, you know, in 30 seconds, what would you say to people who might think of hospital at home as something only for patients who are wealthy or not sort of facing the social determinants of health that we've talked about?
30-second version. Most of the patients who have that financial security generally don't need our help. They're doing a lot of their follow-up appointments. They have people who can get them there. So it's actually the complete opposite. It's great coffee, book, conversation type of information when you start to open their eyes to what we're actually able to accomplish within a home and how we're going about it to think outside the box. Eyes are wide. I deal with it daily. You know, I don't understand, you know, physicians, I don't understand how you're doing this. And once you talk to them about the actual tools that we utilize, the remote monitoring that we utilize, the equipment and things that we can bring into the home to care for these patients, they very quickly continue asking more questions. But what about this? But what about this? We're a concierge care that is serving all of our community. You don't have to only visit one section of the county in order to receive it.
Perfect. I think that's a great place to end, and really just kind of drives home everything we all have talked about in preparing for this presentation, which is health equity, you know, just means that everyone, you know, has what they need to live their healthiest lives. Some, you know, need more, some need little. And equity is not the same as equality. It's what you give people and what they need so that they can sort of have the same thing, which is to be healthy. So appreciate that. Rachel, any questions from the chat?
We don't. So I'll just ask Jessie to move us to the next slide. And yeah, before everyone leaves the webinar today, I just want to make you aware of our next webinar, which is at the end of June. So we'll be focusing on, the topic will be proactive clinical response for care at home, digital nursing and virtual command centres. So everyone that's here joining us today, we will email you an invite to join this webinar should you wish to join. But just to wrap up, I just want to thank Tracey, Jessie and Melissa for a great conversation today. Thanks, Melissa, in particular, for taking time out of your day to share your insight with us all. So thanks very much. Have a good rest of your day.
Thanks, Melissa, and to your team.
Thank you. Thank you so much, guys. Thanks for your support.
Thank you.